All right. Sorry about that. Let me just get set up here. Okay, Allison, thank you so much for that really lovely introduction and for inviting me to join you today. It is a pleasure to be here. And hello to everyone out there who is tuning in. I'm really excited to share with you a bit about what I do as a neurooptometrist and talk about the impact of neurodegenerative conditions on our vision, maybe in a way that you're not really familiar with. So my goal today is to make this presentation useful and interactive. Like Allison mentioned, we will save some time at the end to discuss questions that you might have. So if anything pops up during the presentation that you would like to ask, feel free to submit it in through the chat box, and we'll do our best to get to everything at the end. So without further ado, I wanted to start by introducing my wonderful and brilliant colleagues. The Pacific Neuroscience Institute now has a team of about 40 physicians who are trained across a wide variety of specialties to treat basically all medical conditions from the neck up. And I think that some of you might recognize a few of the faces here. I know some of my colleagues work very closely with cognitive care solutions, and I think a handful of have actually done presentations on this same platform before. I, in particular, work closely with our brain health providers. Those are Dr. Petrosian, Dr. Porter, Dr. Buxton, Dr. Merrill, and Dr. Miller, as well as my neuro-ophthalmology colleagues, Drs. Kraus and Solomon. I see patients at both our Arizona and 1301 locations. They're actually only a few blocks away from each other. But if you are seeing one of our brain health providers, you might be familiar with that 1301 building. Our brain health department is just downstairs from my office. I do not have any financial disclosures. To give you a clear roadmap for today's talk, this is sort of the framework that we'll follow. So I'll start by talking about the visual system and our ocular anatomy, just give a brief overview of how our eye works. And then I'll introduce you to neurooptometry and tell you kind of what it's all about, why it's different than routine eye care. And I'll describe what happens in a neurooptometric eye exam. I'll also touch on some visual and functional changes that a patient with a neurodegenerative disease might be noticing. And then we'll talk about some potential treatment strategies for how to overcome some of those deficiencies. I'll also talk more broadly about practical tips for maintaining our eye health and taking good care of our eyes. And then we'll kind of wrap up and talk about some exciting things that are hopefully coming soon in the future of eye care and finish with that question and discussion portion. I wanted to start today with kind of a fun visual riddle. This is called a rebus puzzle, and it is a picture representation of a common word or phrase. I really love these because they involve a combination of both visual and spatial clues, and you have to be kind of clever and creative to solve them. So can anyone guess the answer here? Feel free to maybe submit it through the chat box. Let's see if I can see the chat box. Perfect, Karen, yes, man overboard. So this was kind of an easier one. I'll show you a few that might be a little bit harder. You can let me know if you can get these ones. I'll give you a minute here, but again, if you can figure out any of these, feel free to submit them in through the chat box. And I will say, I think they get a little bit progressively harder. Okay, so I'm seeing a couple correct answers here. The first one on the left side is think outside the box. If we look at the middle riddle, there's 1, 2, 3, 4 gives and 1, 2, 3, 4 gets. So that one is forgive and forget. And the last one is objectively the hardest one here. If you look at the shape of goodbye, it's kind of in that wave pattern. So this one is supposed to be wave goodbye. But great job, everyone. I think this is just a fun way to kind of get warmed up, think about using our brain. I know that Allison uses these sometimes in some of her cognitive exercises, and you can certainly find these online. So if you're looking for it, again, it's called a rebus puzzle. Now that we're warmed up, let's talk about why we're here. I think most people recognize that vision is important. We know that it plays a really central role in how we interact with and interpret the world around us. But I don't know if people know that vision is actually physically our dominant sense. So our visual system is processing the majority of our sensory input. More than 50% of our body's sensory nerves are actually located within the eyes. In addition to that, we have 12 cranial nerves, and 6 of those are somehow involved in how our eyes work. They're either supporting our sensory functions, which allow us to see, or they're helping us to move our eyes and eyelids. And I think that these facts really highlight how integral vision has been evolutionarily and how important it continues to be to the human experience, because so much of our body is physically designed to help process visual input. And in the context of neurodegenerative diseases and aging, vision is really important because it's neuroplastic. And that means that it's adaptive and flexible when in response to things like disease or injury. Our eyes and brain really do everything that they can to help us see clearly. And oftentimes that allows us to overcome some, difficult challenges. Before we dive into the specifics, I wanted to give a general overview of the visual system. Our visual system is a really intricate network that includes our eyes, our brain, and all the pathways that connect them to each other. Research suggests that visual processing uses nearly half of our brain's functional areas. And that's because vision is really not just about our eyes and seeing, but vision is deeply connected to so many of our other basic functions, things like motor control and coordination and balance, and of course, cognitive processing. And those abilities are the foundations for really basic activities of daily life. Even something like brushing our teeth or taking a shower, walking out to the street to get the mail, or talking to friends and family, require these types of skills. So of course, I'm a little bit biased, but I think that the eye is a really extraordinary organ, and it's worth knowing and understanding some basic anatomy to get a better idea of how the eye works. So we'll consider a few of the most important structures here, which I've circled in red. And we could spend days talking about the anatomy of the eye and how it works. But I'll spare you from that, and we'll kind of break it down and think about the eye functioning like a camera. So if we start from the front of the eye, the cornea is that clear dome-shaped tissue that covers the colored part of our eye, which is called our iris. In our camera analogy, the cornea acts like a camera lens, so it's bending and focusing light inside of our system. Our cornea is also highly innervated. It's one of the most innervated tissues in our body, and that makes it really sensitive to things like pain from a cut or an infection, or even something like mild dryness. This is really the part of our eye that's responsible for telling us when something is wrong. Our pupil is the adjustable opening in the center of our iris, and it's actually sort of a blank space, and it controls how much light is entering into our eye. We can think of this working like a camera aperture, so it's constricting and expanding to control the amount of light that enters the system. The lens sits directly behind our pupil, and that's focusing light onto our retina. So it's kind of like the fine focusing ability that a camera lens might have. And what that's doing is allowing us to see things both far away and then changing our focus to look at something up close. In addition, the lens is our eye's natural UV filter. So it's absorbing harmful light rays and preventing them from getting inside of our eye. During a lifetime, our lens is also continually growing and expanding. So I compare it to like a piece of plastic. If you leave it out in the sun for too long, how it gets kind of like yellow and brittle. And that's sort of what happens with the lens in our eye. And that's sort of the way that a cataract forms. So if we move through to the back of the eye, the retina is the light sensitive tissue that covers the entire inner portion of our eye. And this is the tissue that converts light into electrical signals in order for our brain to process. Within our retina is the macula, which is a small central part of our eye. And this is the part of our eye that aligns with an image when we're looking at something. So if I look to the left or I look to the right, my macula is the part of my eye that remains looking at that image. And that's because it's allowing us the sharpest and clearest vision. Some of you may also have heard of the macula because this is the part of our eye that's affected by a disease called age-related macular degeneration. Finally, we'll talk about the optic nerve, which is a bundle of sometimes more than 1 million nerve fibers, and it's constantly transmitting all of that visual information from our retina to our brain. It's sort of analogous to a cable that you might use to connect your camera to a computer. I don't know if anyone is doing this anymore, but when I used to have a point and shoot camera, you would plug it into your computer with a cable to send over the images onto your computer and allow you to edit them or process them. And that's sort of the function of our optic nerve. Glaucoma is a disease that can cause permanent damage to these fibers, and unfortunately can result in loss of vision here. So once those electrical signals are sent from our eyes via the optic nerve, it follows what's called the primary visual pathway. And this pathway is really responsible for reorganizing visual information and preparing it to be processed. So if we look at this schematic here, and we look at the field of vision, that teal part is highlighting the right side of our field of vision in both the right eye and the left eye. And that information is actually being captured by the left side of both of our eyes. And as we follow the optic nerve, once we get to the optic chiasm, which is kind of that X in the middle of the brain, we can see that all of the visual information from the right side of our field of vision in both eyes is being collected and combined and sent to the left side of our primary visual cortex. Similarly, information from the left side of our field of vision ends up being seen, so to speak, by the right side of our eye and going to the right side of our brain. And from here, it actually even gets more complicated. Information from our primary visual cortex is sent to higher order visual processing areas for further interpretation. So this is where questions like, where am I, where is it, and what is it are answered. And this type of information is supporting much more complicated visual functions, things like our subconscious vision, our reflexive visual responses, our spatial awareness, and our visual motor coordination. So when we consider both our primary visual pathway and the secondary visual pathway, they're really enabling a huge range of visual function. And as you can imagine, damage to any part of these pathways or multiple parts of these pathways can have really significant implications on how we see. As an eye care provider, I think this is one of the most fascinating parts of taking care of my patients, because sometimes a specific area of injury leads to a really specific change in vision. So the way that a patient might present in my clinic can whether that is what they can see or what they can't see, sometimes that can really localize exactly where damage happened in their brain. We think of this frequently when we're talking about a patient who might have had a stroke. If a patient has had a stroke in the left side of their brain, we might expect to see a field cut on the right side of their vision and vice versa. And again, that's just related to the way that all of our visual information is processed within our brain. And this is one of the reasons why we think of our eyes as an extension of the brain. Now that we have an understanding of ocular anatomy and the visual pathways, and we can sort of appreciate how complex the eye really is, I wanted to share this campaign with you that the American Optometric Association put together recently. And I think it's really fabulous for a few reasons. But what they did is they took a human eye and they compared it to a smartphone and kind of put things into perspective how powerful the human eye is. So the newest iPhone 16 Pro Max has 8 gigabytes of random access memory. It has a 48 megapixel camera and it has a 4K display. Then what they did was sort of translate the capabilities of the human visual system into these same technical specifications so that we could kind of appreciate the power of the eye. The human eye would have 2.5 million gigabytes of random access memory, a 576 megapixel camera, and a 14K equivalent display. So this is one of those reasons why when you are taking a photo of a sunset, for example, it just never looks as good as it does through your own eyes. And that's really because our eyes are even now so much more advanced than the technology that we have available. So anyway, this is just a really great campaign. I think the AOA did a great job with it. If you are interested in seeing the full campaign, the website that they've put together is seetheeye.com, and it's beautifully put together. There's graphics and it's interactive. There's really interesting tidbits about eyes and vision. So I'd encourage you to check it out. And now I'll introduce neurooptometry, and I want to start by first defining it. Neurooptometry is a specialty within optometry that involves the evaluation and diagnosis and management of neurological conditions that may affect the visual system. Neurooptometric exams really focus on unique needs and vision changes that are experienced by patients who have a neurodegenerative diagnosis, and they're often problem-driven. So like Allison had mentioned at the start of lecture, I see patients who have a neurodegenerative condition, something like Alzheimer's or Parkinson's, dementia, patients who might have memory problems or have had a stroke or a brain tumor. But I also see patients who have symptoms that may be neurological in nature. So something like double vision or headaches or missing parts of their fields of vision. Generally speaking, I think neurooptometrists tend to work really closely with other healthcare providers, and that's because we sort of have this shared goal of improving a patient's quality of life by addressing visual changes that might arise from neurological conditions. So you're probably wondering, what happens during a neurooptometric eye exam and why that might be different than the eye exams that you're used to receiving in a primary, optometrist or ophthalmology office. And the difference here is where a traditional eye exam primarily focuses on ocular health and the need for glasses, a neurooptometric exam focuses more specifically on those connections between our eyes and our visual system. Because we're thinking of our eyes as an extension of the brain, I support that there is benefit in every patient who has a neurodegenerative condition to have an eye exam, even if you don't necessarily have specific visual concerns. And these exams are supplemental to rather than substitutional to your routine eye care. So, my intention is never to replace an optometrist or ophthalmologist that you're already seeing, but it's really just to give you more information about your visual system and the way that your eyes work. And I help patients understand what part of vision changes might be related to the disease that they have and what changes might be more related to just normal age-related changes or some other kind of unrelated ocular disease. I've listed a few of the tests that we commonly perform during an eye exam, but of course, each patient is different and therefore each exam is different. I'm really considering history and symptoms and of course, patient concerns in determining exactly what happens inside of our clinic. And as a whole, this information is helping us to understand functional aspects of vision, and that can help to explain visual performance and also identifies how visual dysfunction might be contributing to other systemic conditions or symptoms that other providers on the care team might be picking up on. So those are things like balance issues or trouble with mobility, even headaches. We also use this information to share with our therapists so that they can help to develop really targeted and effective rehab plans. Let's talk a bit about how some of these visual changes might manifest in a patient who has a neurodegenerative condition. A patient's vision might look something like this, where it's just really difficult to see any fine details. We can sort of tell that it looks like there's two people who are walking down a pathway. There might be some people in front of them. There might be some trees on the side of this pathway, but we're unable to see anything sharply or clearly or really determine any fine details from it. Or a patient's vision might look something like this, where instead of seeing one hand with 4 fingers, we're seeing 2 hands and 8 fingers. And you can imagine how if you were walking around the world like this and seeing 2 of everything, it would be really visually disorienting. And it's hard to tell which of those images is the real image and which is kind of the secondary or ghost image. Other times patients are seeing something else entirely. Sometimes they have a hard time describing those vision changes. And, oftentimes a patient will end up in my exam chair saying, Dr. Holmes, I'm not exactly sure what's going on with my vision, but I just don't see well, or I'm unsatisfied with my vision. Other times they do have these specific concerns, like, I used to be able to read the newspaper every morning and I can't do that anymore, or I'm feeling unsafe when I'm driving, or I'm seeing 2 of things that I know I should see 1 of. And this variety of presentations is all pretty normal for this patient population. Sometimes they've even had an eye exam already and been told, everything looks normal with your eyes, everything was fine. So how exactly do neurodegenerative conditions affect the eyes? We know that commonly prescribed medications, especially for Parkinson's and Alzheimer's, are often linked to dry eye. And while I know that that sounds fairly benign, dry eye not only can have a really significant impact on clarity of vision, but it can also be painful. Our eye muscles can sometimes end up misaligned, or damage to the nerves that innervate the eyes can cause double vision, which we clinically call diplopia. And more subtle vision changes are something like poor depth perception or poor contrast sensitivity. Depth perception is how we judge distances between 2 objects, and contrast sensitivity is how we discriminate an image from its background. As you can imagine, both of these elements of vision are really important for things like mobility and safety. One that doesn't get brought up quite as often is that patients sometimes experience forms of visual hallucinations, and these can vary really broadly. Sometimes I'll have patients say, it just feels like there's someone walking behind me, and when I turn to look, there's nothing there. That's actually a known phenomenon. It's called passage illusion. Or those visual hallucinations can be much more formed and complex. I have had patients tell me every once in a while when they're in their kitchen, they'll see, monkeys dancing on the kitchen countertops, or that there'll be a familiar face sitting across from them at the dinner table. And unfortunately, these vision changes are confounded by other age-related conditions like cataracts or diseases like macular degeneration, glaucoma, or diabetic retinopathy. Of course, any of those things can make any of these problems worse, in addition to having their own visual problems. And I'll add here that this is by no means a comprehensive list of vision changes that happen in patients who have a neurodegenerative diagnosis. My colleague, Dr. Solomon, who's a neuro-ophthalmologist here, has a really great lecture that is specifically on eye issues that happen in patients who have Parkinson's, and that's available online in case any of you are interested and want to dive into this topic a little bit deeper. So I've linked that at the end. This slide highlights some of the functional challenges that patients with a neurodegenerative diagnosis might be facing because of those visual impairments. And these are issues that I often work closely with the rest of a patient's care team with, because they're often multifactorial. One implication is impaired balance and mobility, poor depth perception or spatial awareness, combined with a neuromuscular condition like Parkinson's or MS, which is already affecting our muscles and posture and gait, can make it really hard to stay steady and to move at the same time. Reading can become challenging. Patients will tell me that it looks like letters are dancing or jittering or floating off the page, that things seem like they're moving, or they might have difficulty just tracking a sentence from one end of the page to the other. They might have difficulty moving their eyes from the end of a sentence to the start of the next sentence, and that's not uncommon either. The brainstem is the part of our brain that kind of initiates those eye movements, and it's often affected by a neurodegenerative disease. Of course, reading also has a cognitive component to it, and if you're reading really slowly and it's hard for you to get from one sentence to the next sentence, or it's taking a long time, of course, that's going to make it harder to then put all of that information together and understand what that sentence is saying. Patients may also appear to be clumsy, and I put this in quotes because it may be caused by something like a change in our depth perception or motor coordination, leading to someone misjudging distances or knocking things over or thinking that their laptop, is a foot away from them, and when they put their coffee down, they're accidentally spilling it all over the laptop. Driving is considered a complex visual task, and this is a big one. Driving also requires the physical ability to handle the steering wheel and press your gas and your brake pedal, and you have to have a quick reaction time. Limitations in vision and or physical ability can cause these sort of unsafe driving scenarios. Finally, navigating stairs and curbs or any kind of unfamiliar or uneven terrain can become hazardous, especially when it's confounded by age or disease-related physical limitations. So if you're trying to walk downstairs and you already have difficulty seeing, then trying to use a cane at the same time is, of course, making that a lot more challenging. And unfortunately, that's increasing your risk of falling or injury, which can further impact your mobility and quality of life. Overall, these implications are just demonstrating how vision deficits extend beyond our eyes and really into our daily life. The good news is that these vision problems are often treatable or at least manageable. I rely heavily on tools like over-the-counter or prescription. Sometimes there are specialty glasses that are designed to help you only for when you're at the computer or for knitting or whatever that specific hobby is that you might have. For a patient who is seeing true binocular double vision, we might consider prism lenses. And there's also a lot of supportive measures that we can do at home. So something like a safe driving assessment or lifestyle and home modifications, which I'll expand a little bit on the next slide. Collaborative care is also a huge one and is something that I really love about working at P&I. Our care team works really closely together, so I'm constantly communicating with a patient's therapist, whether that be their occupational therapist, their physical therapist, their speech language therapist, their neurologist, and their psychiatrist. We're all working together to really consider a patient holistically. I've included some supportive measures here that are relatively easy to implement at home in case some of these might be useful to you. I love a desk lamp with an adjustable arm, and that's because it allows you to direct not only the light, but also direct the glare that comes off of it. And we know just as we have more birthdays, our pupil gets smaller and you're probably developing some type of cataract, and both of those things are limiting how much light enters our eye. Light is really the foundation for how we see. So sometimes by just adding a little bit more light to the environment, it can really make a difference in how clearly we're able to see. Motion activated lights are another great one that improves safety. They're automatically turning on when you walk by them. So not only are they illuminating dim spaces, but they can also help to orient a person. And it means that you don't have to be, searching for the light switch on the wall anymore. Simplifying environments is also helpful. So if you look at that image in the top middle, it's almost hard to see what it is, but it's a bathroom counter, and you can tell there's just a lot of clutter there. If you're able to organize spaces so that everything kind of has a home, we call that reducing visual clutter, and that makes it a lot easier to find something. So if you know that your toothbrush lives in the cup to the right of the sink, it's a lot easier to identify it than trying to find it in a different place every time. The image below that, unfortunately, this is the best image that I could find, but I was trying to illustrate the difference that contrast makes. So again, to remind you, contrast is our ability to differentiate an image or an object from whatever is behind it. So this is a plate of spaghetti, and on the right-hand side is a plate of spaghetti on a red colored plate and a red colored tablecloth. And you can tell it's kind of hard to see where your food starts and where the plate starts and where the tablecloth starts. On the other side is spaghetti on a white plate and a black tablecloth, and it's much easier to be visually oriented here. So this is an easy way to make meal times easier. You can think of eating light foods on a dark colored plate and using a dark colored plate to eat lighter colored foods off of. On the top right, that's what's called a line guide. And this is a super simple tool that can be really helpful for something like reading. It's just helping you to stay on track. It's blocking out some of that visual noise. And these are really great because you don't have to purchase one. You can just use a piece of paper that's flipped over. Something like that can often be enough just to be able to read a sentence or a page clearly again. And these are just a few examples of some kind of low-tech measures that might improve daily life, but I'm always customizing these recommendations to a patient based on their visual functions and their visual goals. Because vision is really the foundation of so much of what we do, optimizing our vision can support both cognitive well-being and our functional health. On the cognitive side of things, having clearer vision just helps to reduce cognitive fatigue or the cognitive load that our brain is responsible for. Our brain is really directing so much of what we do, and it wants us to see clearly. So when it's not, it's putting a lot of effort into that task. And sometimes, that can affect our reading comprehension or memory or attention or multitasking. On the other side of things, when we're talking about our functional well-being, having clear vision helps with our mobility, it helps with our independence, and it reduces our risk of falls and accidents. So clear vision is helping us to stay safe. The other point that is worth bringing up here is that sometimes a vision impairment or poor visual processing can actually mimic cognitive decline. So a patient might seem like they are presenting with early symptoms of memory loss or Alzheimer's, but in reality, they just have a really bad cataract or something like that. Now that we've discussed the value of vision, I want to focus on some proactive measures that we can take to maintain our eye health. So I put together a little do and don't list here. We'll run through these. Do wear sunglasses and safety glasses. When you're picking out sunglasses, look for something that's 100% UVA and UVB protection. Typically, even cheap drugstore sunglasses will offer this kind of protection, but you should be able to see that sticker on the lenses. And I also always recommend considering safety glasses, especially for things like handling chemicals, even if that's just like cleaning with bleach. If you are playing any kind of sport that has a ball that might fit perfectly into your eye socket, so anything kind of smaller than a tennis ball. If you are woodworking or have hobbies that might expose you to the risk of something flying into your eye, make sure you're wearing safety goggles or glasses. And the other time that I think about safety glasses is in someone who might have lost vision already, either in one eye or has some type of permanent vision loss from an eye disease. Wearing glasses full time that are made of an impact resistant material can just be an additional barrier between your eyes and the rest of the world. So if, for example, you're in a car accident, God forbid, or something like that, it's just a shield to help protect your eyes. Do you practice good eye hygiene? That means washing your hands before you touch your eyes. If you have a lot of debris and dandruff, or you've been told that you have blepharitis or Demodex by one of your eye care providers, it can be a good idea just to keep your lids and lashes clean. I often tell patients that it's helpful to incorporate this into your normal kind of hygiene routine. So the same as we brush our teeth and we wash our hair, you might need to clean your eyelashes and lids just to give your eyes a little bit of extra love. Do get good sleep, do exercise, and have a healthy diet. We know that restorative sleep allows our eyes to rest and repair. You're looking at that golden kind of 7 to 9 hour window. Exercise, of course, is good for our overall health. It promotes blood flow to our eyes, which gets nutrients and oxygen to them. And it helps to relieve eye strain, especially if you have been sitting down and looking at a screen all day. In terms of diet, we're thinking about foods that are rich in antioxidants and omega-3s. The Mediterranean diet is really great for that. Do wear proper glasses. This sounds kind of silly to say, but I can't tell you how often I'll have a patient come into my office and say, I don't know, bring 10 pairs of glasses with them and say, I don't know what any of these do. I don't know which ones are my reading glasses and which ones are my driving glasses. So if you have multiple pairs of glasses, make sure you know which ones are for what function. And if it requires you to put a label on them or color them somehow, just make sure that you know that you're using the right pair. The other thing that I wanted to bring up here is that if you are at risk of falling or have had recent falls or you just feel kind of unsteady, I would recommend getting a pair of single vision distance glasses if you don't have them already. So that means that if you're wearing a progressive or a bifocal, you're considering something else. And that's because the magnification that you get on the bottom of those lenses will make it look like the stairs are closer to you than they really are. And that can just increase your chance of having another fall. Do control systemic conditions, especially those cardiovascular conditions. So things like hypertension, diabetes, high cholesterol. When uncontrolled, all of those can increase our risk of developing certain eye diseases. And in advanced cases, they can be vision threatening. Moving over to the don't side of our list, don't rub your eyes. I know it can be really tempting, but rubbing our eyes can just move something around inside of your eyes, and that can make a problem worse, can increase your risk of getting a cut or an infection in your eye. And of course, it doesn't unfortunately address the cause of your eyes being itchy in the first place. Similarly, if you have any red eye relief drops, you can just go ahead and throw those in the trash. It's a Band-Aid solution that masks the problem. But what happens with red eye relief drops is that they work by constricting the blood vessels in the front of your eyes, but they're related to what's called rebound inflammation. So once that drop wears off, the redness typically comes back and it's worse than it was initially. And that kind of puts patients on the cycle of dependence where you use a drop, your eye gets better, the drop wears off, your eye gets red again, and you put another drop in. So instead of using a red eye relief drop, try to use an artificial tear instead. Don't smoke. You know that smoking is bad for your systemic health. It is also not good for your eyes. Smoking has been directly linked to progression in macular degeneration and thyroid eye disease, and smoke itself can be an irritant to the front of our eyes. Even these small habits can make a really big impact over the course of months or years of your life. So I'd encourage you to pick some of these up if you aren't doing them already. And, lastly, and most importantly, don't ignore symptoms and don't neglect your eye health. On that note, you should be having an eye exam at least once a year. This is from the American Optometric Association and their evidence-based clinical practice guidelines that were released in 2023. So they recommend that anyone who is 65 years of age or older be having an annual eye exam. And this is that routine eye care your optometrist or your ophthalmologist that you're likely already established with. Of course, you might have more frequent eye exams than that if you have risk factors or an ocular disease or condition that requires monitoring or treatment. And if you are younger than 65 but over 18, the AOA also recommends that you have an annual eye exam, but that's more a consensus expert opinion rather than an evidence-based recommendation. I personally recommend having an eye exam on an annual basis if you are able to. And that's because you might be surprised to learn that there are 270 systemic and chronic diseases that can be picked up during an eye exam. An eye exam is one of the only ways that you can actually visualize the inside of your body, short of something like an X-ray or a CT scan or an invasive surgery. So it really is this kind of window into your soul and the rest of your body. And I'd encourage you to get an eye exam, even if you don't have concerns about your eyes or vision. Again, it's just this good impetus to check your eyes to look for other things. And as we wrap up here, I wanted to talk about the role of caregivers. I imagine that some of you on the call here might be caregivers, and I wanted to review a couple of ways that you can support your loved ones. Firstly, observe and report changes in their vision or their eye health. Sometimes patients have a hard time noticing changes that they're personally experiencing. That's because those changes might be gradual, or they might have good vision in one eye or something like that. Encourage them to use the proper glasses like we talked about before. Label them, know which ones go for which ones should be used for what task, and help them manage their visual aids. So, if they've been recommended to use a magnifier or lighting, etc. Help implement some of those changes at home. Simple things like removing loose wires or cords, low-lying furniture, decluttering the house to remove that visual noise can be really helpful. I wanted to touch on offering emotional support as well. And caregivers tend to be wonderful at this, but this is really important as it relates to visual changes because visual changes are often subjective. Other people can't notice them or experience them. It's not the same as when someone has a broken arm and we can see that their arm is broken. So having these visual changes and a caregiver who can validate those feelings and those changes and provide reassurance can really go a long way. Advocate for your loved one. If you are able to attend appointments with them, it can be really, really helpful. Oftentimes patients end up in my office and they immediately forget the reason why they've come to see me. And if a caregiver is able to attend the appointment, they can kind of be a second voice. If you can't attend that appointment, if there's a way you can communicate those concerns ahead of time, I think all of patients' providers would be grateful for that. And of course, prioritize your own self-care. You must take care of yourself in order to take care of others. So just let this be a gentle reminder to you to take some time for yourself and be kind to yourself. As we look ahead, the future of neurooptometry and eye care in general, I think holds incredible promise in transforming how we approach neurodegenerative conditions and other ocular diseases and really optimize vision care. I've highlighted some key areas where I think advancements will have a significant impact on how we take care of patients. The first is in disease detection. Advancements in imaging technologies and artificial intelligence and machine learning are helping us to detect diseases even before symptoms emerge. And that is allowing us to have this sort of crucial window for early intervention. And it's applying to all kinds of different retinal and ocular conditions, being able to detect patterns and subtleties that might be missed through traditional diagnostic methods or just human limitations. Personalized treatment, I think, is really the future of eye care, but also more broadly, healthcare. Being able to consider genetic data and lifestyle factors and using advanced imaging to create these custom treatment plans will help us much more effectively address disease. Vision restoration has been a hot topic in eye care for many years. From a bionic eye to adaptive lenses and other assistive technologies, we're seeing really rapid advancements here. I imagine that many of you are using Siri on your phone or Alexa at home, and these have become incredibly helpful tools, especially to those people who have visual impairments. The first full eye transplant actually happened somewhat recently in May of 2023. And I think the next hurdle here is now, how do we repair the optic nerve and how do we restore function to the retina? I'm optimistic that in my lifetime we will see that. Pharmacological advancements are also huge. They're enabling the development of not only much more targeted therapies that have less toxicity, but we're also coming up with really creative ways of delivering medications, things like implants that allow for continuous medical dosing and improved compliance on a patient's end. So it's an exciting time to be in eye care, and I truly believe that we're at this intersection of technology and medicine and patient-centered care. And all of these things will help us better treat eye diseases, but also improve the quality of life of our patients by enhancing these cognitive and functional abilities. I wanted to highlight one technology in particular that I'm really excited about. This is an emerging technology and it's called retinal image analysis. So our retina, again, is that inside part of our eye. And we've learned that there are structural and functional changes in retinal blood vessels that might serve as surrogate biomarkers and help us to detect for diseases like Alzheimer's. So this is an image on the top is a patient's eye who has Alzheimer's, and on the bottom is an age-matched control who does not have any disease. And you can see that there's differences in the blood vessel density and perfusion, which is the amount of blood flow. So in that patient with Alzheimer's, there are fewer blood vessels and not as good perfusion. And these specific correlations are being studied really broadly. There are companies like ReadySpec that are actually teaching artificial intelligence how to detect amyloid beta plaques and tau protein deposits that are in the retina. And I think this has the potential to be a really disruptive technology. These markers right now are being detected through pretty invasive procedures, something like a cerebrospinal fluid analysis, which requires a lumbar puncture, or a really costly method like a PET scan. None of these are, screening tools. So being able to offer non-invasive, accessible options to potentially detect these diseases very early on, I think would be a huge game changer. And again, this type of technology is really still in early stages. It needs research and clinical validation, but it is exciting nonetheless. This is a quote actually from a previous professor of mine at Berkeley Optometry. He founded a company that offers telehealth services, and he said that the possibilities for AI to improve eye care are truly limitless, but we're just beginning to imagine the scope. And I think that's really true. We don't even know what we don't know, so I'm excited to see what's ahead. And to recap here, our vision and brain health are interconnected. Neurodegenerative conditions impact both our cognitive function and our vision, and addressing these visual changes can help to improve our quality of life. Neurooptometry can make a difference. Specialized eye care can improve visual processing and reduce symptoms and enhance daily functioning. Maintaining our eye health is critical. Take good care of your most advanced technology, so to speak. Watch for symptoms and changes in vision, and don't wait to act on those. Caregivers can help to implement practical strategies and can communicate their vision-related observations to eye care providers. And the future is really bright. There are exciting technological advancements ahead. So with that, I'll kind of move into some of the resources before we do a Q&A here. So again, I work at the Pacific Neuroscience Institute. My department is within the Pacific Eye, Ear, and Skull Base Center. So our website and phone number is there. The Brain Health Department is a separate department. That's where our neurologists, psychiatrists, neuropsychologists, geriatric medicine physicians are. And within the Brain Health Department is Brain Wellness and Lifestyle. It's a separate program that offers really wonderful personalized consultations, activities for brain health, and support groups. This is a link to Dr. Solomon's webinar on visual changes in Parkinson's that I had referenced earlier. That was part of a reoccurring webinar on everything Parkinson's. So if you are interested in learning more about Parkinson's, you can RSVP to Giselle at that email or phone number and join those regular webinars. Another great resource for webinars on our website is through the Brain Wellness and Lifestyle program. Molly Raposo, who is a dietitian nutritionist with us, has some really great lectures on a variety of topics. And if you are interested in finding a neurooptometrist or a neuroophthalmologist and you are not local to the Los Angeles area, I've given you two resources here. The first is through the Neuro-Optometric Rehabilitation Association, and the other is through the North American Neuro-Ophthalmology Society. So with that, I think we can move into the Q&A portion of today.